Chapter 19, Part 1, Cardiac Anatomy, Screen 2. This screencast is going to be focusing primarily on the superficial and external anatomy of the heart, but there is something that I would like to address first. And by now, you know that I am a big fan of terminology used correctly. And many textbooks will indicate that the atrium and ventricle are prominent external structures. I want you to keep in mind, remember, atria and ventricles are chambers. They are space with a muscular wall, and unless you have x-ray vision, you really cannot see them from the outside. So this may be a technicality, but it is something that I feel pretty strongly about. Other things that we are going to see that are predominantly visible from the anterior portion are going to be all of the great veins. So the aorta, the vena cavas, if we look, pulmonary trunk, pulmonary veins, and so on. Other structures that appear are going to be the auricles. They are rather wrinkled and are quite often referred to or appear like elephant ear flaps. So that's something to keep in mind when we are looking at the anterior view of the heart itself. Now, as noted, I do not consider the atria and ventricles to be predominantly visible from the outside, as they are chambers, unlike what our textbook says. But here we're looking at the posterior view of the heart. And if we look at some things that are a little bit more visible from the backside, are going to be many of the vessels. We can more clearly see the left and right pulmonary arteries. We also have a better view of the vena cavas, but what really stands predominant are going to be a number of the coronary veins, predominantly the coronary sinus, very clear here from this particular view of the heart itself. Now, when we look at some superficial features that are rather predominant, sulci is one of them. And remember, a sulcus is basically a groove. Now, what is going to be important about the sulci of the heart, this is where all of the coronary arteries will be nested. So they are within these grooves of the heart itself. And if we look at some of them, let's break them down. We have the coronary sulcus. This is separating the atria from the ventricles. Think of it as a groove that's extending around the circumference from the heart. We have an interventricular sulci. This is going to be separating the ventricles from each other. These grooves, once again, are going to be where we find the coronary vessels that are responsible for the blood supply to the heart. Keep in mind, when we address the blood supply of the heart cannot access the blood that's moving through it. It's just a pump. So being as metabolic as it is, the heart is going to need its own system of blood vessels to meet the demand of heart work. Now, when we look at layers, this is something that I tend to ask pretty regularly. When we look at differences between the wall of the right ventricle and left ventricle, what should be obvious, and if we kind of go back to when we were dissecting the fresh heart, I think it was much more obvious than when we looked at the heart models that the thickness of the left ventricular wall is so much greater than that of the right ventricle. But remember, when we look at the jobs of the right ventricle versus the left ventricle, the job of the left ventricle is to generate a pressure gradient that is strong enough to move blood through the systemic circulation, whereas the job of the right ventricle is to move blood through the pulmonary circulation, so it does not have to generate as much of a force as does the left ventricle. Now, when we look at the layers, there are three layers. We have the epicardium, which is the visceral, and that is the visceral pericardium, and that is the outermost of the layers. The largest and thickest of the layers is the myocardium, and this is the actual functioning part of the ventricle. This is the wall of the heart, and it's muscular in nature. So this is what's responsible for generating the contractile force generated by the heart itself. Then we have the endocardium. This is going to be covering the internal surface, and it basically is a simple squamous endothelial layer. And remember, when we talk about a simple layer, it is not a protective layer. We consider it to be a covering for the most part. But one thing to remember here is when we look at this endocardium, this endothelial layer is continuous with the lining of blood vessels. This is important because when we start talking about blood vessels, one thing that we will address is internal damage to the wall of the vessel and the role that that plays with respect to atherosclerosis and heart disease. Now here we're looking at the internal anatomy of the heart, and I'm not going to spend a lot of time here as this was primarily a lab activity in which we're responsible for learning the primary structures of the heart, both internal and external. Now, one structure that is internal that I do want to put an emphasis on are going to be the valves. This was addressed earlier, and one thing that I want to address about the valves, the general job of a valve is to make sure that a fluid is moving in a single direction. Now, this is what I said earlier with respect to the function of the heart. What the heart does, it generates pressure. Valves will open and close based on changes in pressure on either side of the valve. Valves will open. Blood will move from high pressure to low pressure through the valves that are actually open. Here, the view that I want to point out is going to be the coronal section or frontal view. Here we can see the two atrioventricular valves, one on the right side, one on the left side, and the role of these valves is to separate the atria from the ventricles. Then we have two semilunar valves, and these are going to be separating a ventricle from an exit vessel. So if we look on the right side, we have the pulmonary semilunar valve. It's separating the right ventricle from the pulmonary trunk. And if we look on the left side, we're going to find the aortic semilunar valve, and this is separating the left ventricle from the aorta. This particular valve is a little bit more difficult to identify when looking at the heart models because it is really kind of tucked behind the valves, and on our models is not always the easiest to see visibly. Now, one thing that is really standing out in this particular image here is the directionality of the cusps or flaps of the valves. So let's look at the AV valves once they are open, and the flow will be from the atria to the ventricles. Notice that the cusp or flaps are in a downward direction. This is going to facilitate the flow of blood through the valve. Here we can actually see the valve, what it looks like when it's closed. When we look at the semilunar valves, we can see that the cusps are in the opposite direction. We're looking at an upward flow of blood out of the ventricles into a particular exit vessel that could be either the aorta or the pulmonary trunk. Here we can see what it looks like when it's closed, and it's going to prevent the backflow of blood back into the ventricle, and we can see that here. Now, there are a couple of issues that are tied into hypertrophy or called as cardiomegaly. This is a situation when the heart becomes enlarged. This is not good. When we look at a large heart, I prefer to use the terminology strong heart as a healthy heart. When we look at a cardiomegaly, the heart is becoming enlarged, and the number one cause of this is high blood pressure. This forces a thickening of the ventricle walls because it has to generate more force to open the semilunar valves. So this can become an issue. So what we see, there's going to be less overlap. We're not going to have as strong of a forceful contraction. And eventually, this could result in congestive heart failure. When we look at hypertrophic cardiomyopathy, this is an inward growth of the heart walls. So now we basically have narrow openings for blood to pass through, and this results in a significant decrease in cardiac output or blood actually leaving the ventricles. Now, another thing that is associated with the valves are heart sounds. There are two familiar sounds. We have S1 and S2. They quite often are described as lub and dup. Lub is S1, that is the closing of the AV valves. S2 is the closing of the semilunar valves. There are other sounds that are clinically useful, but not used all that often. Now, a condition that is specific to valves are heart murmurs. Now, keep in mind, imagine you're a child going to a pediatrician and they determine that there is a heart murmur. One of the things that you will discover, they're not often seriously concerned about a heart murmur, especially if it is not symptomatic. Because keep in mind, the child is still growing. And as they grow, there is a strong likelihood that after growth, the valve will sit appropriately and there no longer will be a murmur. Now, two types of valve murmurs are as follows. You have a valvular insufficiency. This is when the valves are actually leaking because the flaps are not closing tightly. This results in a regurgitation of blood moving back through the valve, and this could result in an enlargement of the heart. There's also something known as a stenosis. This happens when the flaps actually become scarred. Scarlet fever is something that is known to cause this particular condition, and because of the scarring, the flaps cannot open completely. So now there's basically going to be this resistance to blood flow, and that is actually going to reduce the output of blood coming from that particular chamber. Now, when we use the term skeleton, think of a framework. So now, the heart does not have an osseous or bony skeleton. It has a fibrous skeleton, and this skeleton consists of dense, irregular connective tissue. So the fibers are not going in a regular manner, okay? But what's happening here is we have this skeleton that is creating structural support for the heart, especially when we look at the boundary of the atria and the ventricles. We'll see these fibrous rings that are created by this fibrous skeleton. This is going to anchor the valves. We'll also see that this also is providing a framework for the attachment of cardiac muscle. Another thing that is associated with the fibrous skeleton is it acts as an electrical insulator. Keep in mind, the function of the heart as excitable tissue is to generate these forceful contractions, and it is electrical in nature. So whenever we have something electrical in nature, there has to be some type of an insulator, and this is preventing ventricles from contracting at the same time as the atria, along with some other anatomical features associated with the heart itself.